Assalamu alaikum. Today I'll be presenting um, randomized controlled clinical trial published at JOAE 2025 titled with endotoxin level after calcium hydroxide placement in root canal irrigated with continuous or sequential chelation in previously treated teeth with symptomatic apical periodontitis. This study tried to investigate whether the continuous chelation can reduce the endotoxin more effectively than the conventional sequential irrigation protocol during non-surgical retreatment of cases with persistent symptomatic apical periodontitis, where the sequential chelation is the conventional protocol by the using of sodium hypochlorite throughout the instrumentation followed by EDTA to remove the semi-layer, while the continuous chelation is the using of single solution, which is a mixture of sodium hypochlorite and 9% of etidronic acids. We all know that apical periodontitis is primarily caused by microorganisms and their byproduct of endotoxin, which is the one of the strongest inflammatory mediators. Previous in vitro study have shown this mixture of solution have um, enhanced the semi-layer removal, improved the penetration into the dentinal tubules, and also enhance the antimicrobial effect. This study want to see is this continuous chelation can improve the reduction of endotoxin level. Where this study investigate two hypotheses. The first, is there a difference between sequential chelation and continuous chelation in endotoxin level? And the second, placing calcium hydroxide would provide an additional reduction in endotoxin level. So this study is prospective double-blinded randomized controlled clinical trial of a total of 48 patients that randomly assigned into two groups. All patients had previously treated with symptomatic apical periodontitis, single-rooted with one canals, and treatment performed for at least 2 years. And the sample were collected at 3 times interval by the using of paper points and quantify by the using of limulus ambusite lysate LAL assay. The sampling were collected um, immediately after gutta percha removal, and also after instrumentation and irrigation, and lastly after placing of calcium hydroxide. The result showed that both irrigation protocols significantly reduced the endotoxin level from T0 to T1 after instrumentation and irrigation. However, continuous chelation consistently produced lower endotoxin level than the sequential chelation. Interestingly, the after calcium hydroxide placement um, significantly improved the endotoxin reduction were only in the sequential chelation group, which is the sodium and EDTA group. While in the continuous chelation group, the adding of calcium hydroxide did not produce any statistical significant benefit, which suggests that the continuous chelation with etidronic acids had less additive value of placing calcium hydroxide between visits. And could be explained by the use of continuous chelation that continuously remove the hard tissue debris and prevent of smear layer accumulation and obstruction with no solution interaction. That results on sodium hypochlorite deeper penetration into the dentinal tubule. So, as a conclusion, despite the strength of this study design that presented with good randomization and good sample size, and none of the cases have dropped out over the group, this study only investigate the endotoxin level with no correlation with the clinical and radiographical outcome. Therefore, we cannot conclude that this lower of endotoxin level necessarily meaning a better clinical outcome.